Yes,
Okay,
absolutely.
all right.
Anytime you're ready.
Okay, so I'll start now. 2 weeks ago, we were talking about how to, my approach when I'm seeing a patient with diabetes, about how to go about the visit, the exam, screening, and what to look for. Today, I'm going to talk about, I'll talk about the same patient that I talked about 2 weeks ago, but this time we'll talk from a different aspect. What can we do to improve not only the diabetes but also the metabolic health of the patient when I'm seeing the patient. So that will be my approach, and hopefully in the next 20-25 minutes, that's what we will be talking about. All right, next slide. I think. Let's see. Okay, so yeah, so this is. Can you hear me? It says your internet connection is unstable. I can. All right, I just
Yes, we
wanted to
can
make
hear
sure.
you.
All right. So remember we talked about this patient 2 weeks ago. Let me just refresh if people are joining me for the first time. So this is a patient who is 48. I'm seeing for diabetes mellitus, and blood sugars are running high. He's 48, non-diabetic for the last 5 years, and he also has history of hypertension along with diabetes. The pertinent exam is that his BMI is 36. Social history, he has sedentary lifestyle, medication, lisinopril 10 milligrams, and full dose of metformin, and also on glimepiride. Patient does not smoke and drink. Blood pressures during the visit are high, 145 and 90, and this will become important. So this is something that we need to address. Last A1C, recent A1C is 7.8, and the lipid panel, which was done recently, fasting, is the LDL was 134, total cholesterol 220, and HDL cholesterol is 34. So LDL is a little high and the HDL is a little low. Next. Okay, so the question here is, what can we do to improve his metabolic health? So we're going to work on the diabetes part, but what can we do to improve his metabolic health? The other way to say the same thing is, what can we do to help this patient live longer and healthier, meaning less complications from his diabetes, less strokes, kidney problems, heart disease, and also what can we do to help him live longer by preventing some of these complications. Next slide, please. So diabetes is really a symptom as far as I'm concerned. In it, the disease really involves the heart, the kidneys, and also the metabolism, the metabolic profile, which means the lipids, and the blood pressure basically, and the weight as well. So if you see this slide, when patients have pre-diabetes or very early in the disease course, they start to develop problems. Besides the hyperglycemia, they will start gaining weight. I'm talking about the type 2 diabetics, like the patient that we discussed. So they will start gaining weight. Their kidney functions, even in early in the course of the disease, their GFR will start to go down, and they will start having some protein loss in the urine. Blood pressures, as the weight goes up and the diabetes slowly begins to rise, blood pressure will increase. The metabolic profile, the lipid panel, the HDL cholesterol, that is one of the commonest things that we see in diabetics. The HDL will start to go down, triglycerides and LDL will start to rise, and all of this will lead to increased cardiovascular risk, even in pre-diabetes. So we need to diagnose patients with diabetes early, screen them early, so that we can start making an intervention when they are in the pre-diabetes and early in the disease course. Now, as the disease advances, it depends on other things as well, like their genetic profile, the environmental factors. Do they smoke? Do they have any other risk factors? But as the disease advances, when they do have type 2 diabetes, then everything is exaggerated. So if you see the blood sugars are running high, they are gaining weight, their insulin resistance is increasing, they are more at risk for developing a non-alcoholic steatohepatitis as a result of that, and the liver damage from that. Blood pressure rises again, which will cause hypertension, hypertensive related changes, atherosclerosis, hardening of the stiffening of the vessels, and eventually acute coronary syndrome. And similarly, the kidney, because of high blood pressure, the GFR will continue to decline, albuminuria, meaning loss of proteins in the urine, will take place, and as a result of that, the electrolyte, the hyperkalemia, and elevated creatinine and anemia from kidney damage will also happen. So to tackle the diabetes, we have to make sure we diagnose them early, and we prevent not only their hyperglycemia but the metabolic profile from the cardiac standpoint, protect their kidneys, and also the blood pressure. Next slide, please. So diabetes effect on the body or an organ. So number one cause of death is cardiovascular mortality in this country at this time. Diabetes affects the cardiovascular system. High blood sugars directly will affect the elasticity of the vessels. So the vessels, the blood vessels will become less elastic. They will become stiff, in other words. So stiffness will lead to increase in blood pressure, because blood pressure is just the pressure on per unit area of the blood wall, vessel wall. So if the vessels are stiff, they will not expand as much, and the blood pressures will rise. And the high blood sugars is making these vessels stiff. So it's not surprising that about 75%, almost 3/4 of the patients with diabetes will have hypertension. So it's extremely common, and again it becomes a vicious cycle. Hyperglycemia is making, high blood sugars is making the vessels stiff. Stiff vessels will develop atherosclerosis and will lead to end organ problem like kidney problems, strokes, and the heart problems. So we need to not only control diabetes but also blood pressure. And this is you all know this. Uncontrolled hypertension will increase the risk of heart attacks, strokes, and the peripheral vascular disease. So these are the macrovascular problems. So the big vessels, the brain vessels, the heart vessels, and the peripheral circulation. So that those will be affected. Next slide. So what can we do to reduce the macrovascular, the stroke, heart disease, and the peripheral vascular disease risk? Of course, be aggressive with the blood sugar control, number one, to prevent the vessels from getting stiffer. If they are smokers, counsel them about stopping smoking. And sometimes this takes multiple attempts, but you have to, keep at it, basically. Manage their blood pressure, and we will talk about this, and the lipids, and this is what we were going to talk about today. Regular exercise. Exercise will help blood pressure, will help weight loss, will help insulin resistance and stiffening of the vessels. Rich fiber diet is another thing that we more fiber, basically less carbs and less fat will help the blood pressure and the blood sugars as well. And then use agents which have established cardiovascular and renal benefits. So this is really important. Now, this patient that we discussed, he was on metformin and glimepiride. So can we add something to improve the diabetes control, help the weight loss, help blood pressure? So that's where these newer agents with cardiovascular benefit and the renal benefits become important. So these injections, the GLP, we are talking about liraglutide and semaglutide, which is Ozempic, Trulicity. And this really is a class effect. So there are certain agents which are better than the other, but by and large, whatever insurance is covering, I think we should try and get this approved for the patient. So I'm talking about the injections and the SGLT2 inhibitors, your empagliflozin, which is Jardiance, and the Invokana, the canagliflozin, and the Farxiga, which is dapagliflozin. These are pills. The important thing to remember here is these SGLT2s are for secondary prevention, meaning in the clinical trials, they have shown that if you already have an established cardiovascular disease, heart attacks, atherosclerosis, then SGLT2 inhibitors will be beneficial. However, the GLPs are beneficial both in terms of primary prevention, meaning preventing an event, and then secondary prevention. For congestive heart failure, however, SGLT2 inhibitors are superior because it has a diuretic effect. So if you have a patient who has established heart disease with congestive heart failure, with normal renal functions, GFR is more than 45, probably SGLT2 inhibitors is better. But the patient that we talked about, who has not developed any problems yet, GLP, because it will also help, Ozempic or Victoza will be a better agent because it will help lose weight as well. So next slide. All right, can you click more? All right, so we'll talk about each of these things. Excellent. So I'm seeing this patient, he's, sitting in the clinic, we said that the blood pressure was about, I think, 140 something, 145 by 76. So these are the things that are in my mind. Is this patient that I'm treating for diabetes at blood pressure targets at this point? Number one. Then if I have to add or start, and this patient was already on lisinopril 10, by the way. So if he's already on a blood pressure agent, is he meeting the targets for the blood pressure? And what agents should be used for to control the blood pressure? This patient was not on a statins, so should we add a statin, and if so, which agent? Again, we are trying to help improve the metabolic profile, so that's why I'm thinking in those lines. I'm not sure if you guys have had to deal with this, but this is a common thing. Statin induced diabetes. Most patients read about it and they ask this question: does use of a statin cause diabetes? And if they already have diabetes, putting them on a statin, will it worsen diabetes? Will it worsen their diabetes control? We get this question commonly. So I will address that as well. What about using aspirin or other antiplatelet therapy? Should all diabetics be on aspirin, or should they not use aspirin? Who should use aspirin? So that we will try and tackle this. And then what can be done to reverse diabetes, cure diabetes, go into remission? So those are some of the things that we try and deal with when we are looking at the metabolic profile. Next slide. Okay, so what are the blood pressure targets? Ideally, in a diabetic, the target blood pressure is less than 130 systolic and less than 85 diastolic. Lower is better, however, if we want to, if we can take them safely without dizziness, without lightheadedness, without increasing the side effects. If we can get them into 120s, that's actually better than 128 or 130. So that's the ideal target. And these are the recommendations. So if you have a confirmed blood pressure in the office setting, which is more than 140 systolic and 90 diastolic, then we, of course, in addition to lifestyle therapy, we should either initiate treatment or titrate the pharmacological therapy to achieve our target. Like this patient that we had discussed, his blood pressure was, I think, 145. So clearly a little high on a low dose of lisinopril, 10 milligrams. So if you're seeing this patient, then you can ask them to check the blood pressures at home more often, and then maybe consider increasing the dose if the patient is tolerating and not having any dizziness. So again, the target is less than 130, 85, lower is better. However, if you are seeing a patient in the office setting and the blood pressure is greater than 160 systolic and 110 or 110 diastolic, then in addition to lifestyle, we should initiate medication, a combination medication. For example, if they are on a lisinopril, we should increase the dose and add hydrochlorothiazide. If they're not on medication, then add a combination medication so that we can bring the blood pressure down and in the target range, which is 130, 85. Again, if you're seeing an elderly patient who has dizziness and lightheadedness and having multiple falls, you can alter this. This is not set in stone. But if you're seeing a young patient, like the patient I described, our target is to bring the blood pressure down to prevent the metabolic complications that the patient is at risk for. And most diabetic patients are at risk for. Next slide, please. Okay, so drugs to treat hypertension. Again, when we're treating diabetes or hypertension, we want to use the agents that have established cardiovascular benefit, that reduce the congestive heart failure, that reduce stroke risk and heart attack risk. So the agents that are commonly used are the ACE inhibitors or the angiotensin receptor blockers. These are the losartans and the valsartans. Thiazide diuretics in combination, and the dihydropyridine calcium channel blockers. So these are your Norvasc, the amlodipine and the felodipine, not the verapamil and the cardizem. Those are the non-dihydropyridine. So these four agents are preferred agents to treat hypertension in patients. So normally we use a combination of ACE and a thiazide diuretic to help control the blood pressure. And so most patients are using combination of either an ACE or an ARB plus a diuretic. we should avoid the combination of an ACE and an ARB because that can lead to hyperkalemia or increased potassium levels. So either use ACE if they develop some kind of cough or they had some, issues on the ACE, then an ARB is a perfectly acceptable alternative. But try and avoid the combination. There is no pharmacological benefit of adding it, and we are increasing the risk of hyperkalemia. So that's one thing. Next slide, please. So an ACE and an ARB again is indicated for blood pressure control in patients who have diabetes with albumin greater than 30. So if they have albuminuria, they have microalbuminuria, some albumin coming out, and they have hypertension, then that's the indication to start the blood pressure medication. Just albuminuria in the initial stages, and then the blood pressures are fine in the target range. Really, it's not a strict indication to the so-called renal protection. That is not a strict indication to use it. But if they have high blood pressure, more than 130 systolic, more than 85 diastolic, then to treat blood pressure and to help albuminuria, we should use the combination. Again, when these patients are on an ACE and an ARB and other blood pressure medications, then yearly, once a year, every year, we should check the potassium, GFR, and creatinine to adjust the treatment. So if the potassium is going up, then maybe it's time to reduce ACE or ARB or add another agent. And if the potassium is running low, then we should readdress how much diuretic or add a potassium to the mix. Next slide, please. So we talked about the blood pressure. What about the lipid lowering therapy or the statin therapy? So, and when we are choosing a statin, which statin to use? Should we use, everyone should be on atorvastatin? Can we use Zocor, which is simvastatin? So any patient with, at any age with diabetes, any diabetes, 1 or 2, they have established cardiovascular disease, meaning they already have a heart attack or a stroke, they should be on high intensity statin. And I will tell you more, talk more about high intensity statin, which agents and which doses are high intensity. So that's the first thing. The second is most all diabetics who are between the ages of 40 and 75 and their risk, and I will show you how to calculate this risk, more than 7.5% for atherosclerotic risk, then they should be on a high intensity statin. And if their risk is less than 7.5 over a period of 10 years, then we can use a moderate intensity statin. Older diabetics, more than 75, with very, no established cardiovascular disease, we can use a moderate intensity statin. And I think you will understand this more when we talk in the next about this in the next few slides. Next slide, please. Okay, so calculating the risk. How do we calculate this risk? So if you just Google or download an app, the ACC or American Heart Association Cardiovascular Risk Calculator, it's free. It will ask you a series of 8 questions. Actually, I have the 6 here and 3 are in the next. 3 are actually in the next slide. It will ask about the age of the patient, gender, race, the total cholesterol, HDL cholesterol, systolic blood pressure, and can you click one more time? Yeah. So is the patient on blood pressure medications? Is the patient smoker or has diabetes? So here I put the numbers in for the patient that we talked about. And then this will give us a 10-year risk, atherosclerotic risk. What is this patient's risk for developing a major cardiovascular event over the next 10 years? So his risk, as you can see here, is about 47, almost 46.5, 47%. So that is higher than the 7.5% that we were talking about. So this patient, based on the guidelines, is at high risk. And this patient will benefit from a high intensity statin, not a low intensity statin. Now, if he cannot tolerate it, and we will talk about it, then a low intensity statin should be okay. But initially, high intensity statin. So I think this is a good tool. You can just download it on your phone. I think the app is free, and of course the Google is free as well. You can, if you but the app, the last time I checked, the app is free, so you don't have to pay for the app. And you all you need to know is the cholesterol, recent cholesterol. Are they taking hypertension medications? Do they have diabetes, and how high their blood pressures are? And you can calculate that risk. Okay, next slide. So what are the high intensity statins and what are the low intensity statins? So these two agents, your Lipitor, which is the atorvastatin, at a dose of 40 or more is a high intensity statin. The Crestor or your rosuvastatin with a dose of 20 and 40 is considered a high intensity statin. So patients whose risk, they have never had any heart disease, but their risk, 10-year risk that you've just calculated is more than 7.5. They should be on a high intensity statin. So remember these two agents and remember the doses. So higher doses, 20 and 40 on the rosuvastatin and 40 and 80 on the atorvastatin. Now, Lipitor or atorvastatin or rosuvastatin at a low dose is moderate intensity statin. And these other agents like Zocor even in the high dose, that's the simvastatin. Even in the high dose is a moderate intensity statin. In a low dose, it becomes a low intensity statin. So if you have an elderly patient who's barely tolerating the statin, but you're worried about the risk and patient has good life expectancy, maybe using Zocor or simvastatin at a low dose, 10 milligrams is okay. But if you have a young patient with a high risk that you have just calculated, then using a high intensity statin is the way to go to reduce the risk. All right. And again, I think you can just save it, write it down in your office somewhere so that you know that to remember the doses, high intensity and the low intensity statins. All right. Next slide, please. Okay, so when should we use the statin plus therapy, meaning add something to the statins? So if you have a patient who has diabetes plus atherosclerotic disease, already had a heart attack, and if their LDL cholesterol is greater than 100 consistently, they are on a maximum dose of a statin. So they are on full dose of a statin, full dose of atorvastatin, they are taking it, and you know that they're taking it because the patient is a reliable patient. Then and their LDL cholesterol is still high, then you can add something to it. The options include the Zetia, which is the ezetimibe, and the PCSK9 inhibitors. If you see here, I have not mentioned about the fibrates, the fenofibrates, the Tricor, or the Lopid. I have not mentioned about them, because these medications, the fibrates, predominantly are for triglycerides. We're talking about the lipid, the LDL, the cardiovascular risk reduction. So these are the agents that have shown consistently in all the trials to reduce the cardiovascular risk. You can use fibrates if if they have heart disease and their triglycerides are consistently more than 500 after you have treated their cholesterol, after you have treated their LDL. So not all diabetics need to be on a statin. If they are following a diet, then and if the triglycerides are coming down, LDL is the main player here. However, if you have a patient who has had pancreatitis from high triglycerides, of course you need to treat at that time, but not from the cardiovascular standpoint. At that time, you are treating it from the pancreatitis standpoint. Triglyceride is a big molecule. It's a much bigger than an LDL, which is a much smaller, and LDL can go into the vessel wall and make it sticky, whereas triglycerides will not cause that. So you need to keep an eye on it. You need to make the diet changes and exercise and high fiber diet. But predominantly, if you want to improve the metabolic profile and the cardiovascular risk, statins, high intensity, low intensity, plus these agents like Zetia and the PCSK9 inhibitors. Okay, next slide. All right, so this is a common term. Most patients who are on the internet, on Facebook, and those, social media, they ask this question. This is, in my view, in the last 2 or 3 years, this has, gained a lot of traction and a lot of popularity. Does statin cause diabetes? And if you have a patient who is on a statin, who has diabetes, if you put them on a high intensity statin, will their diabetes control get worse? Common question. So what do we know? So I mean, you don't need to know this, but the information is actually good information that we have about it. 2010, a meta-analysis was done. Different studies, they pooled the studies and see what to study this. So the 91,000 patients were enrolled in that study, and they noted that on statin, about 9% patients did develop diabetes when they were put on statin. So that's a good number, 9% of the patients. But if you read between the lines and evaluate it, these patients who develop diabetes, these 9% patients, they had significant risk factors for diabetes. They had pre-diabetes to begin with. So is it just because of the statin they developed diabetes, or just was the disease course that they developed diabetes? They were obese. Some of them were morbidly obese. They had obstructive sleep apnea, and they of course had high cholesterol panel. So these were patients most likely they were destined to develop diabetes. So it's not that the statins made them have diabetes; it just unmasked their diabetes. So the data right now is statins has a chance, a small chance of inducing diabetes, but not in a normal individual, not in all patients. If you already have risk factors, all these risk factors, pre-diabetes, obesity, and sedentary lifestyle, then, and there is no substantial increase in the blood sugars when you put the patients on a statin, even high intensity statin. So putting them on a statin will not make their diabetes worse. This is also studied. So if you are seeing a patient who is on or who already has diabetes, we know we can reduce the risk. We can reduce the heart disease. We can reduce the stroke, improve the renal outcomes by using statin without any effect on the blood sugars, if they continue to do everything else like the diet and exercise. So that is the information on that. Next slide, please. This is also very common. You start the patient on a statin. Next time they come in, they tell you that they are not taking it because their muscles hurt or their joints hurt. Extremely common. So this is so statins can cause rhabdomyolysis, muscle damage, which is extremely uncommon. That means severe pain and very high CPK or muscle enzyme. So that is a different entity altogether. These patients are reporting muscle aches and pains, here and there. They hurt, their legs hurt, they can barely walk. So this is called statin associated muscle symptoms. So this is a broad term, and also called SAMS, statin induced muscle symptoms. In my view, about 10 to 20% of the patients will report some of these symptoms. However, when they are reporting this, we have to just be very careful and pay attention to them, because that does not mean that the statin needs to be stopped. The benefit of the statins far outweigh any risk of rhabdo that is associated with it. When they are reporting this, we should make sure that this is not rhabdo, it's not severe pain. We should also check a CPK, the muscle enzyme, to see if it's less than 5 times the upper limit. So if it's still mildly elevated, then it is not a major concern. 10% of the patient will report some SAMS, which is the statin-induced muscle symptoms. This was noted in the studies as well. However, the incidence was much lower. So some of this is what is called as the nocebo. It's the opposite of the placebo effect, because there's so much talk about statins causing these. Some patients, when you tell them that you want to start them on statin, they will tell you, my friend was started on this medication and they could barely walk on this medication. So some of this is what they're hearing from their friends, what they're reading online and on social media and those kind of things. So some of this is just a mental thing, a mind effect. So you tell them that we're going to monitor it, and if they develop a problem, then we have backup strategies as well. And this is what I want to talk about. So the patient needs to understand that one symptom, one day, if they on the weekend they mowed their grass and they cannot walk, the next day, that is not an indication to stop the statin. All right, next slide, please. So what should we do? I mean, this is I think too much information, but what you need to do is, once the patient starts reporting these symptoms, you need to talk to them. You need to check their CPK, and then you reassess the benefits. You tell them, look, you already have heart disease. We can prevent the stroke and the cardiovascular risk and stuff. And then you evaluate and confirm the diagnosis. So what you can do at that time is to rule out some factors that can contribute to muscle aches and pains. For example, hypothyroidism. Can cause muscle problem, myopathy. So we will need to make sure that they don't have an undiagnosed or an undertreated hypothyroidism. We need to fix that. That will help the muscle symptoms. Vitamin D deficiency. These patients are more prone to developing their muscle symptoms. So we need to be aggressive with the vitamin D replacement. If they have any underlying muscle condition, they have muscle problems to begin with, we need to address that. And then we need to reassure the patient that this develops, this is common. However, we can come up with an alternative statin, a different kind of a statin, and a different dosing schedule. So what I mean by that is, if suppose they developed a problem on a high intensity statin, you put them on atorvastatin 40 and they had all the problems, then what you can do is you can maybe reduce the dose, use a 20 milligram, or use an alternate day therapy. Rather than them taking it every day, take it 3 days a week. If they're still having the problem, then you can use a low intensity statin or a moderate intensity statin. So we need to at least challenge them 3 times with different statins before we can classify this as a statin failure or intolerant to statin. And even if they are intolerant to statin, the new agents, the PCSK9 inhibitors, which are injectables, especially if they have they have risk factors, and those can be prescribed to these patients. Next slide. Now, some of this, and I just want to highlight this, coenzyme Q. Some patients will take coenzyme Q because their pharmacist told them to use the coenzyme Q, and that helps with the muscle symptoms. Well, if the patient is taking coenzyme Q and reporting some benefit, then I will not stop it. I will let them continue it because that is enabling them to take the statin. However, in the studies, it didn't show any major benefit. It didn't show any harm, but it didn't show any benefit. So if they are already taking it and they're tolerating the statin because they think that that's what is causing it, is helping them, then fine, I'll continue with that. Alternative statin, again, rosuvastatin, which is Crestor, and pravastatin, which is Pravachol. They do not go through this cytochrome 3A enzyme. So if they are already on a different medication, like a fibrate, which goes through the same, and that is causing the statin levels to go up and causing the muscle aches and pains, then of course you need to get rid of the fibrate if that is not really indicated to begin with. But you can use either Crestor or Pravachol. These are better tolerated in this situation. So you can, and then of course I already talked about this off-label statin dosing, which may be every other day, 3 days a week. If they cannot tolerate 3 days a week, then a long-acting statin like a Crestor once a week is okay, because again, any statin is better than no statin for these patients. So that is also important. So off-label use, coenzyme Q, make sure that they're not hypothyroid, untreated, or undertreated, and then vitamin D status, and then alternative scheduling. Next slide. Okay, so we talked about blood pressure medications, we talked about statin use. Now what about aspirin? So if patient already have established cardiovascular or beneficial, so aspirin a dose of 75 to 1 milligram per day is indicated for these patients for secondary prevention, to prevent another episode of a TIE or a stroke. However, if they have a strong risk profile, if you're worried about them having a stroke on account of their family history factors, then you can give them aspirin. However, you have to be mindful
of the I apologize cutting you off, but the connection seems a little bit choppy there. Are you able to hear us?
I can hear you. Yes, I can.
Okay.
Can you hear me now?
I can hear you now, yes. It was a little choppy there for a moment. I apologize for cutting you off.
Okay, that's all right. All right, so for secondary prevention, yes, we should give it to them. For primary prevention, we have to balance. Do they have bleeding risk? Are they elderly? They're on a lot of medication, and most likely I will not give them aspirin, or not recommend that they take aspirin at that point. Next slide, please. All right, so what can we do to reverse diabetes? Is there anything we can do, especially if the patient is newly diagnosed within the first year, within the first 8 years? So can we reverse diabetes? Yes, bariatric surgery or metabolic surgery is the way to go. If you see a young patient in their 30s, 40s, you can offer it to them, and they are obese, you can offer bariatric surgery to them as a mean to, make the diabetes go away and go in remission as long as they keep the weight off. So these are the two methods that are mostly done. This is the Roux-en-Y gastric bypass. So if you see here, they've cut the stomach, detached it, pulled the ileum up and attached it, and you see this Y formation. That's why it's called the Roux-en-Y gastric bypass. So they have a much smaller stomach. Because of this, they have a small stomach, so they cannot eat as much. And also this will cause their gut hormones, the GLPs, and so GLP, which is the glucagon-like peptide, is a gut hormone which will go up and will suppress their appetite, will stimulate the pancreas to release insulin, and because of that they will lose weight and their diabetes can go into remission. Now, if you do it soon, within first few years of diagnosis, within 8 years of diagnosis, most likely the pancreas are still viable and will respond to this surgery. But after 8 years, they will get the other benefit, the weight loss benefit, the hypertension benefit, but probably, and their insulin doses will go down, but most likely their diabetes at that time will not go into remission. So this here is the gastric sleeve, where they cut the piece of the stomach. So the stomach here is no longer big, it's like cut here. They staple it and they just remove it. So this is a much smaller stomach. So the food is going to go down quickly, and the release of these gut hormones will be more exaggerated, which will act on the pancreas and help the pancreas. All right, next slide. I think we are about done. So yeah, this is, so what are the indications? When will the insurance pay for it? So we have to take this into consideration. I will start from here. So if the patient has a BMI which is more than 30, most of our diabetics have a BMI more than 30, then the surgery, unfortunately, the insurance will only pay for the laparoscopic assisted gastric bending at that time. So the bending where they put a staple, they will not pay for sleeve, the surgery that we talked about, or gastric bypass. If they have a BMI between 30 and 35 plus obesity related complications like diabetes, then some insurances will pay for laparoscopic assisted gastric bending. However, if the patient has a BMI of, if a diabetic has a BMI greater than 35, this will be classified as an obesity related complication, and the surgery will be paid by most commercial insurances. So they will pay for laparoscopic sleeve or gastric bypass. Any patient with a BMI more than 40, which is considered morbid obesity, even if they don't have any complications, they don't have diabetes, they don't have arthritis, obstructive sleep apnea, the insurances, commercial insurances will pay for it, because eventually this will lead to diabetes and complications, so they will pay for it upfront. Next slide, please. So this is just the same, we will, same thing, after the gastric bypass or sleeve, the glucose will start to return to normal even before they have lost weight. So you don't need to lose weight to get the benefit. And again, this is because they have a smaller stomach, and the gut hormones, the food is going down into the stomach much quicker, because the stomach is either very, very small in the case of gastric bypass, or it's reduced in 50%. So this will lead to the release of these hormones, which will act on the pancreas and improve the performance of the pancreas. And their insulin resistance will start to go down significantly the next day. Again, they have not lost weight yet. So there are some direct weight loss related effects, benefits, and there are some effects that are unrelated to weight loss. And that is just because we are changing the anatomy and the gut hormones are going up, which is helping the pancreas to release insulin. So again, the sooner you do have this procedure done early in the course of the disease, there is a good chance that the diabetes may be reversed. So 8 years is the magic number seen in the studies. So young diabetic diagnosed recently, 2 or 3 years ago, start talking about bariatric surgery, start giving them the option, especially if the BMI is more than 35. Next slide. Click one more time so that we can see the entire thing. Okay, very good. Okay, so coming back to this patient and about his metabolic profile, a few things. I already mentioned that he's on lisinopril. He was not on the full dose. He's only on glimepiride and metformin. His BMI is 36, which is more than 35. He is not on a statin. He has sedentary lifestyle. His lipid panel, and we calculated his risk based on that American Heart Association risk calculator. It was about 46. So what should we do? His blood pressure is higher than the target. The target was about 130/85. So he is high. I think it's time to increase his lisinopril. If he's not complaining of any dizziness and lightheadedness, ask him to check his blood pressures and make sure that they're coming down less than 135/80. Because of his risk, he needs a high intensity statin. So let's start with a atorvastatin 40 or 80, or a Crestor 20 or 40 milligrams. He does not need aspirin. He has not had any cardiovascular events. So I will not start him on aspirin. I'll probably add GLP-1, a weekly injection or a daily injection, because those are the agents that will help with the primary prevention. And because his BMI is 36 and he has diabetes complication, I will discuss as to, I'll probably ask him, what does he think about having a bariatric surgery done? Of course, he needs to do the dieting, the exercising, watch his diet first. And if he's not successful, if he cannot do it, and because he's relatively young, 48, then that will be an option. He has history. He was diagnosed with diabetes 5 years ago. So he's still in that 8-year period where if he had the procedure done, his diabetes may go into remission. So yeah, that is the kind of approach, and that's what I'm thinking when I'm seeing these patients in terms of the metabolic profile. And I think that's the last slide.
That was excellent. Thank you so much, Dr. Hutter, for informative information there. So before we get into questions, we did get a question in the chat, but Dr. Rexroad also chatted in saying your student downloaded the app right now, and it is in fact free. So I just wanted to say that out loud. Thanks for checking that, Dr. Rexroad. So the question we got in the chat, so when following a new patient, A1C initially maybe 12, and to help understand compliance, what would you expect to see in A1C at 3 months recheck, just to indicate a better glucose control?
Sure. Okay, so if I'm understanding the question correctly, so the A1C was 12, and now on a follow-up visit, how much will this A1C, lower number will indicate the compliance of the patient? Is that the question? All right. So, two things. Yeah, so two things. A1C reflects blood sugars in the last 3 months. So if the A1C was 12 and the patient is consistently following the plan, then the A1C should come down. And more than the A1C, what are the blood sugars? Because the blood sugars should come down slowly. If your patient has an A1C of 12, that means that the blood sugars are about 300 plus, 320. So I won't be, if I'm seeing this patient for the first time, in the first month, I don't want to be too aggressive with the control. I want to slowly bring down the numbers. So first month, my target will be around maybe 180 to 250 because of the relative hypoglycemia. If you drop it too fast, the patient will feel the symptoms. So the first month, my target is different. Next month, they'll send the blood sugars. I'll slowly bring them to the target range. So A1C will lag behind those changes because again, in the first month, and again, A1C reflects 3-month control. So the first month, my target really was not the ideal control. So blood sugars will be very helpful. A1C is affected mostly by the blood sugars in the last 1 month, and less so. So about 60% of the A1C performance is what happens to the blood sugars in the last 1 month, and about 40% in the last 2 months. So A1C will be a little misleading immediately in the first setting. So blood sugars are more useful. Again, they have to check the blood sugars, because checking the blood sugars, I don't think you can be aggressive in making changes in the insulin regimen to begin with. So blood sugars are more important than A1C in the first 3 months, especially if you're bringing down the A1C from 12 down to the target range.
Excellent. Thank you so much. Amy, was there any follow-up question you'd like to ask, or was that all set? Oh, I think your audio may not be working. But yeah, certainly feel free to chat in if there is any follow-up question as well. Thank you, Dr. Heder. Are there any other questions, comments, thoughts for Dr. Heder?
Thank you for the presentation. It was nice. Actually, I was in between the lectures, so I'm not sure whether I heard you completely. Did you talk about thinking of putting people on statin and aspirin for people who are more than 75?
Yeah, so I did. If they are more, and if they have good quality of life, meaning they're active, they're still living in the community, then yes, you can consider, if they have diabetes, you should consider giving them a low intensity statin, like Zocor or Simvastatin. So I will put them on it because again, it reduces the primary cardiovascular risk. If they are in a nursing home and they are poor life expectancy, then no, I will not give them because of the risk. Regarding the aspirin, if they already have cardiovascular disease, had a TIA or a stent put in, I will give them aspirin. If they have never had a stent or no cardiovascular event, then I will look at the risk and benefit. Are they at risk for developing GI bleed, fall risk? And in that situation, if their fall risk or if their bleeding risk is much higher, then I will not. But even if the risk is lower and they're otherwise in good health, I will give them a low dose aspirin to prevent this from happening for primary prevention.
Okay. And just like you mentioned about statin, maybe an alternate day or even a weekly. Do you think same about aspirin? Like if they, for any reason.
Right. So aspirin has a half-life of around 7 days. It affects the platelet function for 7 to 8 days. So in theory, this will work. But the recommendation is a daily aspirin, a low dose daily aspirin to achieve a cumulative effect rather than a big dose of 325 or a higher dose. So if they're doing a 325, they can do it a week, once a week or every other day. But if you're doing 81 or a 164, then it's a daily dose.
Okay.
So we
Thank
did
you.
get the follow-up question as well. So correct me if I am asking this incorrectly, but what would a target for an AM blood sugar be, and what would 2 hours after meals target range that indicates AC insulin regimen is effective?
Okay, so the ideal range target is about 100 to 140 in the morning fasting. That's the target. This is the ideal target. 2 hours after, between 140 to 180, closer to 140 if possible. So again, similarly, 100 to 140, 100 close to 100. That's the ideal number. But again, the target varies. Who are we are treating? Again, elderly patients, if you're targeting 100, then we are running the risk of low sugar. One day they didn't eat or exercise or did something, then they will be lower. So that target can vary, but the ideal numbers are 100 to 140. Some people say 120, but 140 is okay because there will be some fluctuations. And then 140 to 180, closer to 140 if we can, after 2 hours after.
Thank you very much. And we got a chat in thanking you, Dr. Heder. It was an excellent didactic.
Appreciate it. Thank you.
Any other comments, thoughts? We have about 10 minutes left, but I don't want to hold you all if there are no further questions. All right. Well, if you all do think of any questions after the fact, as always, feel free to reach out to me via email, and I'll make sure to have them addressed. Just a few housekeeping announcements. So our next session will be on August 12th. I can't believe I'm already saying August. And Cherie Bryan will be providing our didactic on insurances. So keep an eye out for that reminder and the link to join for that session. Thanks to everyone for joining today. Thank you so much, Dr. Heder, for that excellent part 2 of your didactic. Really appreciate it. And we'll see you all next time. Thank you.
Thank you.
Bye.